Hi everyone, my name is Megh Marathe and I use they them pronouns. I'm a PhD candidate at the University of Michigan and my research interests are situated at the intersection of workplace studies and medical anthropology. I'm here today to present joint work with my advisor, Professor Kentaro Toyama. The central emphasis of our paper is that in practice, medical diagnosis accounts for information well beyond the patient's physiology, even for conditions that are considered physiological. This has important implications for those who seek to support medical diagnosis through decision support systems. We use the case of epilepsy to present an in-depth sociotechnical understanding of diagnostic work in hospital settings. We draw upon observational fieldwork and interviews conducted with neurologists over a period of 15 months. Epilepsy is a chronic illness and disability characterized by recurrent and unpredictable seizures. Electroencephalograms are the primary diagnostic test for epilepsy, and EEGs are devices that record electrochemical activity in the patient's brain and display it in the form of brainwaves. Outside the epilepsy subspecialty, the common understanding is that EEG brainwaves and other physiological data, like MRI images, are by themselves sufficient for diagnosis. For example, seizure detection systems are typically trained and evaluated on datasets of brainwaves. However, what we see in practice is quite different. One day, neurologist Dr. Brenda was reading the EEG for a patient being evaluated for infantile spasms. Infantile spasms are an epilepsy syndrome characterized by short, whole body seizures in very young babies. Infants are known to be particularly wiggly, that is, they move around a lot, and hence their EEGs are allowed a very high threshold of abnormality. Dr. Brenda had already acquired a sense for this patient's normal brainwaves, and she was scrolling through the EEG at a steady pace, watchful for deviations in the brainwaves and in the video recording from the patient room. Suddenly, the baby stretched out, almost threw out its arms and legs in a movement indicative of an infantile spasm. Dr. Brenda also noticed the abrupt and distinctive abnormal pattern that erupted in the baby's brainwaves and paused. She used her mouse to position the EEG cursor a few seconds before the pattern, and then keeping her eyes trained on the video, she slowly dragged the cursor over the brainwaves and watched the spasm-like movement in slow motion. She then watched the movement once more, this time balancing her gaze between the brainwaves and the video, because in a real seizure, brainwaves turn abnormal before the start of patient symptoms. But it was hard to tell which came first. However, in the blurry background of the video, Dr. Brenda noticed that someone left the baby's room and closed the door. She repositioned the EEG cursor to before the potential seizure, turned up the volume of her computer's speakers, and set the brainwaves and video to play automatically. We heard the loud chuck bash of a hospital door closing immediately before the baby threw out its arms and legs. Shaking her head in disbelief, Dr. Brenda labeled the event artifact, ? Door closed. In discussion with the attending neurologist, Dr. Brenda removed the question mark from her label a few hours later. This scene previews some of our findings and shows that in practice, medical diagnosis is a relational, situated, and evolving process. In particular, normal and abnormal brainwave patterns are not universally defined, but specific to the patient and their context. The brainwaves of babies, for example, are allowed a high threshold of abnormality. In addition, diagnosis is partly determined by social and environmental factors, such as the activities of caregivers and other healthcare workers, and even the closing of a door. Finally, diagnostic classifications are collaborative and they change over time. An event that was originally considered a seizure comes to be seen as clinically irrelevant artifact and vice versa. Our paper contributes a broader sociotechnical perspective to discussions on intelligent and data-driven decision support in healthcare. Thank you for watching this video, and we invite you to read our paper for more information.